Welcome to BioBits and Bytes.
Today, we are undertaking a deep dive into what many consider the final frontier of, well, material science meeting human biology.
We're talking about the world of self-healing tissues and smart scaffolds.
And it's a field that is moving with just astonishing speed.
That's right. And the core driver behind all of this research is a massive and growing biological bottleneck.
Organ shortage?
Exactly. The global demand for organ transplants vastly outweighs the supply. It's a heartbreaking crisis that just gets worse every year as populations age.
And traditional solutions, they just can't keep up.
So that's where this field, regenerative medicine, or RM, comes in.
Right. It's stepping up to fundamentally change that entire equation by providing innovative donor organ substitutes.
And our mission for this deep dive is to really uncover the science behind these advanced biomaterials. These are materials designed to perfectly interact with living systems.
We want to understand the mechanics of self-healing, how scientists are engineering them to mimic the intricate blueprints of our own native tissue.
And we'll look at their groundbreaking applications, from resolving things like chronic wounds all the way to mending complex damage like spinal cord injuries.
It's a huge scope.
It is. And to start, I think we need a core analogy. Think of regenerative medicine not as simply replacing a damaged part, but more like giving the body the perfect architectural plans.
And all the necessary building materials.
Right, to build the part itself.
Yeah.
It's all about leveraging the body's innate capacity for repair.
And that architectural blueprint, the material support structure that holds it all together, that's what we call the scaffold.
The ultimate biological construction zone.
Exactly. It provides the structure while at the same time it's facilitating the body's own repair crew.
Okay, so before we talk about the architecture of that scaffold, we have to talk about the construction workers on site.
The cells.
The cells. The entire foundation of regenerative medicine relies on stem cells, or SCs.
And when we define them, simply, they're basically unspecialized cells in the body.
Right, and they possess two really remarkable capabilities. First, they can self-renew. They can just make copies of themselves, almost indefinitely.
And second, they can differentiate.
Meaning they can mature into specialized cell types, whether that's a blood cell, a neuron, or a cartilage cell.
And that transition, from unspecialized to specialized, that's the magic ingredient we're trying to harness.
Early in development, cells have this power called totipotency.
The ability to become any cell type, anything at all, including the placenta.
But for repair, we're usually looking for cells with pluripotency.
Right, meaning they can become nearly any cell type in the body, just not the placenta. And that transition to targeted potential was a major early scientific milestone that really made RM a practical reality.
But using these cells often meant relying on embryonic sources.
Which brings up a whole host of ethical concerns and, crucially, the massive issue of immune rejection.
Because the cells aren't genetically matched to the person receiving them.
That is precisely where the major breakthrough known as induced pluripotent stem cells, or iPSCs, just revolutionized the entire field.
This is where researchers found a way to take adult, specialized cells, like simple skin cells, and using specific reprogramming factors.
The famous Yamanaka factors, often.
Right. They effectively rewind the clock on these cells.
Let's pause and really think about that. You're saying they take a fully mature, specialized cell, and they genetically trick it into forgetting what it is.
And acting like an embryonic stem cell again.
Yes. They are reprogrammed to act like pluripotent cells. This is just a massive game changer for sourcing cells.
Why?
Because we can generate patient-specific cells. If you need a new piece of heart tissue, we can take your skin cell, turn it into an iPSC, differentiate that into a heart muscle cell, and then implant it.
So you avoid both the ethical concerns linked to embryonic stem cells.
And more importantly, you completely sidestep the whole issue of immune rejection. It paves the way for truly personalized regenerative therapies.
Okay, but if iPSCs are this incredible game changer because they avoid rejection, why are we still spending time studying other cell sources? What is the technical trade-off we accept when using iPSCs?
That's a really critical question, because while iPSCs are amazing, the reprogramming process itself is complex. It's resource-intensive.
And not always perfect, I imagine.
Exactly. Sometimes the derived cells can retain a kind of epigenetic memory of what they used to be.
So a skin cell might still have some skinness to it.
In a way, yes, and that can affect consistency. Furthermore, some early studies indicated a slightly higher risk of tumorigenicity, tumor formation.
That's a serious concern.
It is, though, that risk is decreasing really rapidly as the protocols get better and better. So for simpler repairs, we might still use adult stem cells, but for complex organ regeneration, iPSCs are often the long-term goal.
So we have these highly capable patient-matched builder cells, the stem cells, but they can't just thrive anywhere.
No, they need the perfect environment to survive, to multiply, and to get their instructions.
Researchers call this ideal microenvironment the stem cell niche.
That's a perfect way to put it. The niche is so critical because it's not just a location, it's an active signaling system.
It's like the control center.
Exactly. It's the specialized locale that provides the perfect cocktail of cues and protection. It's what tells the stem cell, stay quiet, survive, and wait for a damage signal.
Or, okay, damage is here, mobilize and start differentiating into bone or nerve or skin.
Precisely.
So what specifically defines that perfect niche? I mean, what are the mechanical, chemical, and biological factors that create that ideal little suite for the cells?
The environment is incredibly dynamic, and it's variable depending on where you're looking, say, in the bone marrow versus a muscle fiber.
Right. Yeah.
But our sources really stress that the niche is defined by a whole constellation of factors. Mechanically, it's defined by stiffness and architecture. The physical matrix has to match the native tissue.
And biochemically.
It's defined by the continuous low-level release of signaling molecules like cytokines and growth factors, and the presence of these adhesive peptides that cells can grab onto.
And even things like oxygen seem to play a role, right?
Absolutely. Oxygen tension is a massive factor. Stem cells often reside in relatively low oxygen or hypoxic environments.
So if the environment becomes too oxygen-rich too quickly?
It can trigger premature differentiation or even cell death. The niche, through all these signals, acts as a sanctuary. It protects the resident stem cells from stimuli that might cause them to die or differentiate unnecessarily.
Then when damage happens,
the niche provides sharp, specific activation signals, prompting the stem cells to emerge, multiply, and develop into fully grown replacement tissue.
okay, so now we loop back to the material side of this equation. If the stem cells are the highly specialized workers,
Then the biomaterial scaffolds are the actual construction site, the framework and the smart raw materials that define that niche.
exactly. We define scaffolds as matrices, which can be made from either synthetic or natural materials.
And they're implanted to provide the crucial spatial conditions needed to restore the tissue's shape and function. They literally provide the template.
Okay, let's unpack this. What is the ultimate goal of implanting a cell-free biomaterial? If you don't put any cells in it, what is it supposed to accomplish beyond just being a structure?
That's a great question. The goal is to promote the inherent ability of the human body to self-heal.
By recruiting the body's own cells.
Precisely. Its own stem cells and growth factors. These scaffolds are dual purpose. First, they provide that necessary three-dimensional structural support for the wound area, preventing it from collapsing.
And second, the smart part.
The smart part is that they are designed to either introduce bioactive substances like preloaded growth factors that attract cells, or, just as importantly, they contain surface chemistries that specifically attract the body's own resident stem cells and immune cells from the surrounding tissue right after the implant is placed.
So they're the initial organizers of the repair effort. They establish that perfect microenvironment, that niche, for the recruited cells to take hold. But to truly succeed in organizing that repair, the scaffold can't feel foreign to the body. It has to look, feel, and signal exactly like the native tissue it's replacing.
Which leads us to the gold standard of biological architecture, the extracellular matrix, or ECM.
The ECM is the body's native biological framework, and it's not inert, right?
Not at all. It's a dynamic, complex meshwork of proteins, sugars, growth factors, primarily collagens, proteoglycans, and elastin.
And it orchestrates cellular behavior.
Yes, by providing essential biomechanical strength, elasticity, and biochemical cues.
So we're talking about biomimicry copying the ECM. Why is copying nature so crucial here?
Because so many current regenerative strategies fail to fully replicate the ECM's complexity.
And that leads to what?
Suboptimal healing.
Suboptimal healing, chronic fibrosis, or even implant rejection. For instance, if a scaffold is too stiff, it can signal the cells to differentiate into bone, even if you're trying to grow soft tissue.
Or if it doesn't have the right adhesive signals, cells just can't anchor and proliferate.
Exactly. It's all about getting those cues right. So what materials are researchers using? to achieve this high level of biomimicry?
We can broadly divide them into natural and synthetic materials, and each one offers different trade-offs.
Let's start with the natural side.
Okay, so on the natural side, one of the most exciting techniques is using ECM-derived scaffolds.
And these are created from animal tissues.
Often, yes. Pig or bovine organs that have been decellularized.
Decellularized. So all the original cells are stripped away using detergents?
You're left with just the scaffolding, the natural framework itself.
The crucial part is what remains.
Yes. This remaining framework still retains crucial biological cues, native growth factors, glycosaminoglycans, and these adhesive motifs, most notably the RGD peptides.
RGD peptides. Break that down for us.
It's short for arginine glycine aspartic acid. It's the critical biological recognition sequence that cells use to anchor themselves to the matrix.
So it's like the handle the cell grabs onto.
Perfect analogy. It regulates cell adhesion, migration, and proliferation.
I see gelatin mentioned constantly in this context. Why is it such a dominant player, especially if we already have this decellularized ECM?
Gelatin is so popular precisely because it's derived from the partial hydrolysis of collagen.
And collagen is the most abundant protein in our native ECM.
Exactly. So it retains many of collagen's advantages. It's readily available, it's cost-effective, biocompatible, and importantly, non-immunogenic.
Meaning it doesn't generally trigger a strong allergic or immune response.
Right.
But these natural polymers, they have limitations, right?
Yeah.
Particularly structural ones, which is why scientists are always tweaking them.
Absolutely. Raw gelatin often lacks the mechanical stability to hold a complex shape at body temperature.
Right.
It would just melt.
So that's why material scientists chemically modify it.
Yes, which results in compounds like gelatin methacryloyl or gelmit.
What's the key modification there?
They add these methacryloyl groups, and what this does is it introduces specific cross-linking points that can be activated by light.
Usually UV or visible light.
Right. And this allows the hydrogel to rapidly solidify into a stable network, which makes it excellent for things like 3D bioprinting and creating custom, geometrically precise scaffolds with tunable stiffness.
And what about other prominent natural biopolymers?
We also rely heavily on biopolymers like alginate. That's derived from brown seaweed.
What makes it so useful?
It readily dissolves in water and forms these robust gels through simple electrostatic interactions with divalent combinations like calcium.
So it gels up really easily.
Very quickly, which makes it ideal for therapeutic delivery systems. And then, of course, there is hyaluronic acid, or HA.
A key component of our connective tissues.
Right. It's known for its extraordinary viscoelasticity and massive water retention capability. It can hold hundreds of times its weight in water.
So it's used in things like joint lubrication and wound healing.
Exactly.
Okay, let's switch to the synthetic side. It sounds like researchers have more granular control over the material properties and mechanics here.
They do.
But maybe they sacrifice some of those native biological cues.
That's the core trade-off. Synthetic supramolecular systems offer just unparalleled flexibility in controlling properties like degradation rate, stiffness, and shape.
So what are we using?
We use materials like block copolymers, diblock, triblock, multiblock, and cyclic oligomers like cyclodextrins and calixarenes.
And these molecules are designed to self-assemble.
Yes, based on non-covalent interactions like hydrogen bonds or hydrophobic forces. This gives them structure without the rigid links you see in traditional plastics.
And this lets us engineer polymers that behave almost like biological tissue. You mentioned an elastin-mimetic polypeptide B9. What made that specific material so groundbreaking for mechanical stability?
So the B9 triblock copolymer was designed to mimic elastin.
The protein that gives tissues like our skin and blood vessels their stretchiness.
Exactly. And its key feature was a very carefully engineered structure, including the presence of glutamic acid residues.
Why was that design so crucial?
Because it prevented a process called coacervation.
Coacervate.
It's a phase separation that occurs when the polymer clumps together. This design prevented that from happening over a wide range of temperatures relevant to the body.
So if the polymer clumped up, it would lose its elasticity and turn into a stiff, useless mass.
Precisely. Preventing coacervation maintains the stretchiness we need.
And the results were good.
The test results were exceptional. The B9 material displayed both elastic, springy, and plastic behavior, meaning it could deform without snapping. It demonstrated remarkable long-term stability in vivo.
How long?
After a full year of implantation, it maintained a tight fibrous capsule, and critically, it showed no calcium deposits.
Which is a huge deal.
A profound deal. To put that in perspective, early synthetic vascular grafts often failed in weeks or months due to inflammation and calcification. Achieving 12 months of stability without major adverse reactions was a benchmark moment for synthetic polymer design.
That B9 example really drives home the idea that synthetic materials are catching up.
Yeah.
Now let's revisit the hydrogel phenomenon, because they seem to be everywhere in this field,
We rely on hydrogels because they're polymer networks with just an extremely high water content, often over 90% water.
which gives them excellent biocompatibility and those soft, tissue-like mechanical properties.
They're essentially the ideal environment for cells to live in, but there's a challenge we have to confront.
Okay, what's the complexity hidden beneath that sauced jello analogy?
What's fascinating here is the trade-off. Natural hydrogels, like gelatin or hyaluronic acid, are highly biocompatible and they mimic the native ECM really well. But because they're so soft and water-rich, they often lack the necessary mechanical strength to hold up in load-bearing applications.
Like rebuilding cartilage or bone or a weight-bearing joint lining?
Exactly. HA hydrogels, for instance, need heavy chemical modification, like additional cross-linking, just to improve their durability enough to survive physiological stress.
So if you want the biological cues of a natural polymer, but you need the sheer strength of something robust, like a bone substitute, you have to start blending materials. You have to build a composite.
Exactly. This leads to the absolute necessity of composites. Polymers alone often face insufficient mechanical strength, forcing researchers to blend them with things like ceramics or high-strength plastics.
Can you give us an example?
A prime example is embedding nanohydroxyapatite.
Which is a ceramic component similar to the mineral phase of bone.
Right. You embed that into a collagen hydrogel. The collagen provides the biological framework, and the ceramic nanoparticles provide the compressive strength needed for bone repair.
And what about replacing extremely tough materials like in orthopedics?
There, we often use reinforced polymers like polyether ketone or PEEK.
Peak.
It's a semi-crystalline thermoplastic. It's found widespread application in orthopedic surgery because of its high compressive strength, superior chemical resistance, and the fact that its mechanical properties are actually pretty close to those of native bone.
So by combining peak with other bioactive materials.
Researchers can create composites that overcome the mechanical insufficiency of polymer-only materials while still promoting tissue integration.
Okay, so we've established that biomaterials are designed to support and repair, but they face this persistent enemy, the immense physiological loads of the body.
Right. Think about every artificial joint or stent or vascular graft you read about. They undergo constant, daily, repeated cyclic loading.
The rhythmic push and pull from movement and blood pressure.
And what that constant stress does, even to a strong material, is it causes fatigue, microcracking, and wear.
It can lead to processes like crazing
That's the formation of internal microfractures that look like white lines.
and plasticizing.
The softening caused by water absorption from the aqueous biological fluids. The result is that traditional materials fail in situ, often years before their expected lifetime.
Which means more highly invasive retrieval and replacement surgery.
Exactly. The body is constantly trying to break the implant down, even without intentional rejection.
This is why the concept of a self-healing material is so transformative. It stops the failure before it becomes catastrophic.
Precisely. We need materials that can halt or even reverse damage autonomously. And this requires a shift in how we design the material itself, moving from inert, static structures to dynamic smart systems.
Let's pause and simplify that part again. If traditional materials just try to slow down damage, how does a true self-healing material achieve sustained repair?
Well, we can categorize them by their mechanism of action. The earliest attempts, what we call the first generation, they focused on halt and fill.
Halt and fill.
This usually involves embedding tiny, brittle microcapsules filled with a liquid healing agent alongside a solid catalyst right within the polymer matrix,
So when a crack propagates, the stress ruptures the capsules.
releasing the agent, which then cures via the catalyst to seal the crack.
That sounds like an elegant, immediate solution, but as you pointed out, it's a single-use fix. Once the microcapsules in a specific area are broken, that area's healing capacity is depleted, right?
That is the core technical concern. First-generation materials suffer from healing agent and catalyst consumption. Their self-healing capacity is depletable and irreversible after the first major damage event.
And that depletion severely limits their long-term clinical viability in tissues that are subject to chronic repetitive stress.
Right. Which brings us to the second generation, which sounds much more durable.
The second generation strives to fully restore the pre-filled material repeatedly throughout its entire lifespan.
And this approach relies on reversible or dynamic chemical linkages,
Okay, so these are bonds that are designed to break under stress.
and then naturally reform when the stress is removed, often requiring no external input or catalyst.
Reversible linkages, so the chemical bonds are breaking and reforming in response to stress almost instantaneously. What kind of bonds are dynamic enough to do that?
They fall into two main categories: non-covalent interactions and dynamic covalent interactions.
Let's start with non-covalent.
Yeah. Non-covalent systems exploit weaker forces like hydrogen bonds, hydrophobic interactions, or metal-ligand coordination. These bonds break very easily, which makes the material highly mobile and easy to heal.
But maybe too weak for high-load applications.
Sometimes, yes. Dynamic covalent interactions, on the other hand, like the shift-based reaction or bornate ester formation, involve bonds that are stronger than non-covalent ones.
But they can still rearrange and reform under specific conditions.
Yes, like mild changes in pH or temperature, which allows for sustained and stronger repair cycles.
This raises the core technical challenge you mentioned earlier. If a material is constantly breaking and reforming bonds to heal, how can it possibly be mechanically strong enough to bear a load, like a weight-bearing joint or a large piece of tendon?
This is the inherent conflict in biomaterials science.
Yeah.
You're trying to reconcile dynamic reversibility
Which requires high polymer chain mobility for healing,
with mechanical durability.
which requires restricted chain movement for stability.
Exactly. If the material is highly mobile, healing is easy, but it's often mechanically weak, limiting the approach mostly to soft hydrogels. If it's too strong and rigid, the dynamic bonds can't rearrange quickly enough to seal a crack.
So how are researchers managing this fundamental trade-off?
The strategic imperative now is the development of hybrid material systems.
Hybrid systems.
These systems integrate dynamic covalent networks, which provide that initial strength and robust healing, with strong supramolecular interactions, which add toughness and additional reversible points.
So they use multiple chemistries together.
Yes, they're sometimes called dual network hydrogels. They manage this trade-off effectively, achieving both high stiffness and autonomous healing capacity, which pushes them toward clinical viability.
Hybrid systems getting the best blend of mechanical strength and continuous healing. Okay, let's talk about delivery. Getting these complex self-healing materials into the body, especially into irregular, hard-to-reach defects, means the procedure has to be minimally invasive.
Which is where the injectable advantage is just essential.
Injectable, shear-thinning, self-healing hydrogels are currently the most strategically viable platform for clinical translation.
For two main reasons. First, they allow for minimally invasive arthroscopic delivery, which is huge for patient recovery and logistics.
And second,
And crucially, they can flow and conform perfectly into irregular defects. Think about a complex, uneven spinal cord lesion or a deep cartilage crater, and then rapidly solidify in situ.
forming a physical support structure that perfectly matches the surrounding geometry.
Precisely.
Let's focus on that term shear thinning, because it sounds like a truly counterintuitive mechanical feat. Can you break down the mechanics for us?
Think about ketchup.
Okay.
When it's sitting in the bottle, it resists flow. It's thick. But when you shake the bottle, you apply shear stress. It instantly fluidizes and flows out.
And when it hits the plate, it immediately stops flowing and recovers its structure.
A shear thinning hydrogel works the same way. Its internal network is temporarily broken by the mechanical force of the syringe plunger. It fluidizes through the needle and then immediately recovers its gel structure upon exiting the capillary.
Trapping the cells or therapeutic agents inside precisely where you need them.
Yes. The key takeaway there is that the material has to be transiently weakened only during the application process, not permanently.
How long does that shear recovery usually take in these successful models?
The successful translational models show recovery in milliseconds, or certainly within a second. That speed is absolutely critical for clinical success because if the recovery is too slow, the material might just diffuse away from the target site before it solidifies.
But here's a crucial technical nuance you highlighted earlier. Measuring injectability accurately is difficult. Why is the standard way of testing rotational rheology insufficient?
It's insufficient because rotational rheology, where you spin a cone or plate against the material, is a good proxy for viscosity, but it fails to capture the flow profile accurately during capillary extrusion.
Which is what happens when you're pushing material through a syringe needle.
Exactly. Rotational rheology can over or underestimate the actual forces applied during injection because hydrogels are highly structured, soft materials that are easily damaged by high shear.
And why does the measurement method matter so much, specifically for cell survival?
It matters everything if you're carrying cells in the hydrogel. When these structured soft materials are extruded through a narrow needle, they don't exhibit standard parabolic flow.
Parabolic flow being where shear rates are highest near the wall and lowest in the center.
Correct. Instead, they exhibit something called plug flow.
Plug flow, what does that imply for the cells riding in the scaffold?
It means the material flows mostly as one intact plug through the center of the syringe or nozzle. It only experiences extremely high shear rates in a very narrow zone right near the capillary wall.
So the central core, where the cells are carried, remains mostly minimum shear.
And that is vital for maintaining cell viability when you're delivering sensitive cell-laden hydrogels, because high shear stress kills cells.
If it was a standard parabolic flow profile, the high shear rate across the whole radius would be just detrimental to cell survival.
Absolutely. So, confirming injectability with specialized capillary rheology, which mimics the real-world flow dynamics, is essential for clinical success and regulatory approval.
Okay, so structural stability and injectability get us into the body. But the long-term future of RM demands that self-healing capacity converges with immune modulation.
Yes. When you implant anything, even the smartest material, the body launches an inflammatory response.
So designing materials that can actively control this environment is vital to prevent chronic fibrosis, scarring, and eventual implant failure.
We're not just building a nice house anymore, we're also telling the occupants, the immune system, how to behave toward that house.
So how is that biological conversation achieved on a cellular level?
We focus heavily on macrophages. They are the cleanup and signaling crew of the immune system.
And these versatile cells have different functional phenotypes.
Right. M1 macrophages are the pro-inflammatory type. They release destructive cytokines, they wall off foreign bodies, and they cause chronic inflammation and scarring. They often lead to failure.
And the other type.
M2 macrophages. They're involved in tissue remodeling, constructive healing, and resolving inflammation.
So the goal of a smart scaffold isn't just to be biocompatible, but to be immunomodulatory.
Yes, to steer the host response toward that beneficial M2 phenotype.
If we can design a biomaterial, maybe by subtly adjusting its stiffness or releasing specific anti-inflammatory molecules, that steers macrophage behavior toward M2.
We fundamentally change the outcome from chronic scarring to functional tissue regeneration.
So if steering M2 behavior is the goal, let's look at a prime example where that M1 state causes constant failure, chronic wounds.
These are incredibly complex. They fail to progress through the normal 4 phases of healing: hemostasis, inflammation, proliferation, and remodeling.
And in chronic conditions like diabetic foot ulcers, the healing process gets indefinitely stuck in that harmful M1 inflammatory state.
And here we see a huge real-world breakthrough directly addressing this M1-M2 dynamic.
What's that?
The FDA has already approved wound management products that include patented self-assembling peptide hydrogels. And these unique materials, licensed by companies like Gel4Med, are being successfully piloted in U.S. hospitals for these challenging chronic conditions.
That is fascinating. Can you elaborate on the mechanism of these self-assembling peptides?
So these peptides, they're short chains of amino acids, the building blocks of proteins, are designed to spontaneously organize themselves into a stable, nanofiber-rich 3D matrix when they're exposed to physiological conditions.
Like salt concentration in the body.
Right. And the self-assembly process creates a scaffold that's compatible with living cells and, crucially, provides mechanical cues that favor M2 macrophage differentiation.
And that encourages fibroblast migration, which is necessary for closing the wound.
Exactly.
And the sources noted that this approach offers significant economic and scalability advantages. Why is that?
Because the innovative materials science approach relies on synthetic peptides. These can be produced efficiently through chemical synthesis in large batches, unlike materials derived from complex biological tissues.
So it simplifies the supply chain, minimizes batch-to-batch variability,
And reduces manufacturing costs, making the therapy much more accessible and scalable for treating the millions of challenging chronic wounds globally.
Now, let's talk about perhaps the most challenging frontier in all regenerative medicine, spinal cord injury, SCI.
Right. This is where those minimally invasive injectable materials are absolutely critical.
Because human SCI lesions are typically uneven, messy cavities where cells have died and inflammation is just rampant.
You need a scaffold that conforms without exerting pressure on the healthy surviving nervous tissue. Injectable systems flow into those irregular defects and act as a stabilizing bridge.
And we're seeing promising results from animal models.
Very promising results using incredibly advanced materials, such as highly permeable DNA supramolecular hydrogels.
DNA hydrogels. So the material structure is built using strands of DNA.
Yes. The structure is based on a reversible base pairing, which gives it those self-healing, shear thinning properties.
And when combined with neural stem cells,
But they've demonstrated the ability to promote neurogenesis, the formation of new nerve cells, as well as the regeneration of oligodendrocytes.
the cells that produce myelin.
And the restoration of myelin structure in severe SCI rat models.
So the scaffold is stabilizing the area and delivering the crucial raw material, the neural stem cells, to that perfect niche you described earlier.
That's the synergy. Another study used an injectable composite hydrogel made from gelatin and cyclodextrin to carry motor neurons derived from embryonic stem cells.
And the results.
They demonstrated measurable functional recovery in the rat models and successfully regulated the neuroinflammatory response around the injury site. The ability to deliver cells directly to the lesion site and protect them from that harsh inflammatory environment is just paramount for functional recovery.
So beyond structural regeneration, biomaterials are now indispensable partners in drug and gene delivery. How do these scaffolds enhance the efficacy and bioavailability of therapeutics?
They act as sophisticated, programmable delivery trucks. They protect sensitive drug cargo from degradation and ensure sustained targeted release.
Like with liposomes.
Exactly. Liposomes, tiny self-assembled phospholipid membrane spheres, are key multi-delivery systems. Researchers have used them to simultaneously deliver two factors, a microRNA and a platelet-derived growth factor,
Why deliver both at once?
to accelerate healing. When delivered to mesenchymal stromal cells in a scaffold, the combination significantly enhances their differentiation into vascular smooth muscle cells,
A process called angiogenesis.
which is essential for repairing skin wounds by ensuring the new tissue has a necessary blood supply.
And we are seeing these technologies used to fight diseases like cancer too, right?
Mhm.
Using the scaffold as a targeted shield or weapon.
Absolutely. This is where smart hydrogels really come into play. They can be designed to respond directly to the disease microenvironment.
How so?
They can be pH responsive, for instance. They'll remain intact in neutral tissue but rapidly degrade to release highly concentrated chemotherapy drugs, specifically in the acidic tumor environment.
That is truly remarkable targeting.
Or they can be thermo or magnetic responsive, allowing doctors to use external fields to trigger drug release or induce hyperthermia heat therapy for tumor ablation.
And they're also being used to create a supportive niche for immunotherapies.
Yes, for adoptive immunotherapies like CAR T cells.
You can deliver CAR T cells directly into solid tumors with these scaffolds.
Injectable scaffolds can do that, yes. The hydrogel provides a temporary, protective environment that prevents the T cells from being immediately destroyed or deactivated by the tumor's harsh environment.
So it boosts their anti-tumor effects and extends their therapeutic window.
Exactly. It's targeted therapy at its finest.
And finally, we can't overlook the role of advanced biomaterials in the recent public health crisis. The speed and efficacy of the COVID-19 response hinged entirely on material science. The mRNA vaccine rollout was just astonishing. What was the critical role of biomaterials there that was often unseen by the public?
The success of the novel mRNA vaccines, like Moderna and BioNTech Pfizer, would not have been achieved without sophisticated delivery systems.
Because the mRNA molecule is incredibly fragile.
It's a single strand of genetic code that's easily degraded by the body's natural enzymes called RNases within minutes. Lipid nanoparticles, or LNPs, were the essential custom-designed delivery vehicle.
So the LNP, the biomaterial, was the protective shield and the access pass for the genetic instruction set.
Precisely. The LNPs protected the mRNA from rapid degradation and crucially facilitated its efficient entry into host cells. Once inside, the LNP released the mRNA, allowing the cell's machinery to produce the spike protein antigen.
Without LNPs, the mRNA vaccine platform would have failed completely.
Completely. And it's not just vaccines. Transplanted mesenchymal stem cells, MSCs, also demonstrated significant potential to improve outcomes for severe COVID-19 patients experiencing cytokine storms and acute respiratory distress syndrome by modulating the immune system.
So to continue delivering these breakthroughs, from self-healing scaffolds to LNP-based drugs, researchers must perfect cell-material interactions at the tiniest level.
At the nanoscale, we're talking about engineering surfaces at the level of individual molecules.
Let's break it down. When cells interact with the material, they look for specific biological cues, like that RGD adhesive motif we discussed earlier.
Yeah.
How tiny and specific does that interaction need to be to dictate a cell's fate?
It is shockingly precise. It really emphasizes the power of nanoscale engineering. Researchers have investigated the importance of RGD nanospacing.
The literal distance between those cell adhesive motifs on a scaffold surface.
Right, they're asking how far apart should these anchoring points be to maximize beneficial cell behavior?
And what did they find? Is it just a matter of more is better, or is there a sweet spot?
There's absolutely a sweet spot, and it is cell type dependent. Studies using human umbilical vein endothelial cells, the cells that line blood vessels, found that cell migration speed actually peaks at a specific nanospacing,
Which is,
around 90 nanometers.
Wait, so if they space the RGD too close or too far apart, the cell migration rate dropped significantly.
It dropped. That means cell behavior is acutely sensitive to the spatial arrangement of cues down to just tens of nanometers.
So at 30 nanometers, the cell struggled to grab and pull itself forward. At 150, the grabs were too far apart. But at 90 nanometers,
The cell's mechanical machinery, the integrins, can engage, release, and re-engage with the RGD motif most efficiently, maximizing migration speed.
that's incredible.
And it's critical because it shows we have to tailor the scaffold geometry not just to the tissue, but to the specific cell type we're trying to encourage to migrate or differentiate. Some cells can sense a difference of even 1 nanometer.
If the design tolerances are that small 90 nanometers, then manufacturing must be equally advanced and controlled.
Which is where advanced manufacturing steps in. It enables us to translate that nanoscale precision into macro-scale structures,
We're moving beyond traditional molding to techniques like 3D bioprinting.
which allows for the layer-by-layer printing of materials with specific sizes and complex morphologies that perfectly mimic natural tissue architecture.
What are some of the most sophisticated printing methods being used to achieve this?
A key innovation is coaxial 3D printing. Instead of printing a solid line, coaxial printing uses 2 concentric nozzles.
So you can print a core material and a shell material simultaneously.
Yes, and that's essential for creating hierarchical structures. For spinal cord repair, for instance, they can print core shell fibers composed of different cell types like Schwann cells in the core and neural stem cells in the shell to mimic the layered structure of native nerve fibers.
And then there's 4D printing. You mentioned that the fourth dimension is time. How does a 3D printed material change shape over time?
4D printing involves materials that are printed in one shape but can change shape or function in a predetermined way over time in response to stimuli.
Stimuli like temperature, pH shifts, or magnetic fields.
Right. For example, a flat scaffold could be printed that, once implanted into the warm body, curls up into a tube to form an artificial blood vessel.
That adaptability is the definition of truly intelligent material design. It means the material can respond to the changing environment of the healing tissue.
It's all about programmed responsiveness. But as materials get more intelligent and complex, the translational gatekeeper, the regulatory process, gets tougher.
What are the main barriers blocking these advanced products from reaching the wider market?
Our sources identify 2 major barriers that form the commercial chasm: scalability and regulatory friction.
Let's start with scalability.
Regenerative products rely on highly controlled, often synthetic, processes or expensive natural raw materials. Successful commercialization requires the development of reliable, low-cost manufacturing processes.
So we need optimization of natural raw material sourcing, like chitosan or gelatin, to ensure the final product is not only effective, but also techno-economically feasible.
Right. If the therapy costs $1 million, it's not going to solve the global transplant shortage.
And on the regulatory side, what keeps the FDA up at night, creating that friction?
The FDA's primary concern is ensuring patient safety due to the widespread, unregulated marketing of unapproved regenerative therapies.
Because these therapies promise cures for currently untreatable conditions, there's a massive market for illicit or unproven treatments.
Exactly. And we have reports of serious harm. Unapproved products, including certain stem cell injections, exosomes, amniotic fluid therapies, have led to patients suffering blindness after unapproved intraocular injections.
And even tumor formation.
Tumor formation from improperly handled stem cells and severe infections due to non-sterile processing. Because many of these novel products are combination products, mixing living cells with complex biomaterials, they require rigorous clinical trial oversight and licensure to guarantee both safety and efficacy.
And bridging that gap from the lab bench to the bedside responsibly is the biggest barrier.
It is. Standardized protocols and rigorous testing are vital to maintaining public trust in this revolutionary science.
This deep dive has covered vast territory, from the molecular components of self-healing to global public health applications. To wrap up, let's quickly recap the 4 key takeaways that every learner should walk away with today.
First, regenerative medicine is urgently addressing the global organ shortage crisis, and its success hinges on developing smart scaffolds that organize the body's self-repair mechanisms by providing the optimal stem cell niche.
Second, the need for sustained implant durability, especially under cyclic loading, means we need self-healing hydrogels. These materials overcome failure by utilizing dynamic, reversible chemistry.
Third, the optimal clinical delivery method is injectable and shear thinning. This platform enables minimally invasive administration into irregular defects like the spinal cord, relying on fluid dynamics like plug flow to protect transplanted cells.
And finally, future success is deeply reliant on immune modulation, designing materials to steer the host response away from destructive inflammation and toward constructive remodeling. This, coupled with scaling highly controlled, nanoscale precise manufacturing, is the path forward.
Now, for a final provocative thought to consider, the complexity of biomaterials engineering is driven by the body's own complexity. We are successfully mimicking the ECM's structure and mechanical cues. We can now build delivery systems like LNPs that bypass natural defenses.
But the deepest challenge remains.
It does. It remains replicating the subtle, time-dependent intelligence of the inflammatory response. If we can truly learn to steer macrophage behavior from inflammation to constructive remodeling, and we're very close to that, what previously irreversible chronic diseases like spinal cord injury or severe chronic organ failure might become genuinely treatable in the next decade.
A question worth building towards. Thank you for joining again.